Ladies and gentlemen, hello. Our project name is Clinical Key for Electrical Stimulation in Physiotherapy and Rehabilitation. It is funded by the Erasmus Plus program of the European Union. The project coordinator is Pamukkale University and the partners are University of Craiova, Hatay Mustafa Kemal University, Başkent University, Süleyman Demirel University, Şiule State University of Applied Science, and Burdur Mehmet Akif Ersoy University. And associated partners are Turkish Physiotherapy Association, Order of Physiotherapists in Romania, Lithuanian Physiotherapy Association, and Estonian Association of Physiotherapists. My presentation is about electrical stimulation of denervated muscles after 3 months. This chapter written by me, Fatma Nur Alçın, lecturer Betül Söylemez from Burdur Mehmet Akif Ersoy University, and Professor Nilüfer Çetişli Korkmaz from Pamukkale University. Denervated skeletal muscle experiences a rapid loss in both mass and contractile power. If the injury involves the lower motor neurons, this atrophy occurs much more severely. Muscle atrophy becomes more complicated with fibrosis within a few months after denervation. In a study in the literature, it was stated that the endoneurium of distal nerve stumps that have been denervated for 1 to 2 months contains axonless Bögner bands. And distal nerve stumps that have been denervated for 4 to 6 months contain an increased amount of collagen and a relatively small number of Schwann cells. The common belief is that due to atrophy, healing fails and denervated muscle fibers are replaced by fat and fibrosis. The literature shows that it takes about 1 month for all motor nerve fibers to grow and cross the nerve suture region. During this time, the distal nerves and muscles are constantly degenerating. Function of the Schwann cells at the distal end gradually weakens as the denervation period is prolonged, and the Schwann cells become apoptotic. Although early denervation has been frequently addressed in both animal and human studies, studies on the long-term effect of denervation are still insufficient. And studies in the literature indicate that nerve cell bodies in the spinal cord and dorsal root ganglia tend to die as the denervation time increases. Schwann cells become apoptotic, and axonal regeneration in the distal stump after prolonged denervation reacts only slightly to the signal expression. Therefore, some of the current studies have reported that electrical stimulation applied after delayed repair of nerve damage in these conditions is unfavorable for nerve regeneration. There is a study in which urgent or 1, 3, or 6 month delayed repair was performed with a nerve graft after sciatic nerve transection was applied to rats. 13 weeks after the repair, the regeneration of spinal motor neurons was evaluated. A dramatic decrease in the number of regenerated motor neurons and myelinated axons in the distal nerve stump was observed in the delayed groups of 3 and 6 months. So, progressive increase in fibrosis and proteoglycan scar markers in the distal nerve was detected with an increase in delayed repair time. This study has indicated that the critical time threshold at which the regeneration result becomes very poor appears to be 3 months. However, the literature shows that Although peripheral nerve regeneration progresses relatively slowly, the decrease in excitability also progresses very slowly, and it is the good news because this also shows that a strong stimulus can still produce a response as long as some contractile tissue is present until 1 to 3 years after denervation. Another study was designed to evaluate the effects of chronic denervation on the capacity of Schwann cells in the distal nerve stem to promote axonal regeneration and remyelinate regenerated axons. In this study, a delayed repair protocol was applied in which the peroneal nerve in the rat was denervated for 0 to 24 weeks before cross-stitching of newly axotomized tibial and chronically denervated peroneal nerve stumps. It has been found that short-term denervation of shorter than 4 weeks doesn't affect axonal regeneration, but longer-term denervation deeply reduces the number of motor neurons and axons in the distal nerve stem. However, the study also states that atrophic Schwann cells retain their capacity to remyelinate renewed axons. These findings also show that chronically denervated Schwann cells show progressive inability to support axonal regeneration, despite which they have a constant capacity to remyelinate renewed axons. So, electrodiagnostic tests should be repeated after the third month of denervation, and treatment should be continued with the appropriate current according to the type of degeneration reaction. In the literature, it has also been proven that stimulation started after the 64th day of denervation increases tetanic tension 37 times for the red soleus muscle. Similar results were obtained with much longer period denervation and stimulated in the last 3 to 8 weeks of denervation of soleus and extensor digitorum longus muscles. Results in the literature support that the recovery of denervated muscle becomes more difficult as the interval between the onset of denervation and the onset of stimulation increases. However, early nerve repair isn't possible in cases where serious soft tissue trauma occurs with wound contamination. After muscular traction nerve damage, surgeons often postpone operative repair for 3 to 6 months to evaluate spontaneous regeneration in clinical evaluation. Electrical stimulation can still increase the regenerative capacity even after the repair of such chronic nerve lesions, but the functional recovery is weaker. Studies in the literature show that the initial duration of neuromuscular electrical stimulation treatment varies between 3 weeks and 4.5 months. If the axon is intact, the injured nerve can be renewed at the rate of 1 inch per month. For these reasons, the first 3 to 6 months are critical for determining the spontaneous recovery. 9 patients who had complete denervation of the tibialis anterior muscles and had undergone between 2 and 40 months after the lesion in this study done by Valencic et al. In 1986. And patients received electrical stimulation with secure wave stimulus on tibialis anterior muscles at 25 hertz for 20 milliseconds for 20 minutes in a session, 2 times in a day 5 days in a week and 3 weeks for a total. And they found increasing the level of foot dorsiflexion and reversing the course of denervation atrophy. In another study, individuals who were diagnosed with facial nerve palsy between 1 and 7 years ago were divided into two groups: those who underwent facial nerve reconstruction surgery and those who didn't. And both groups are divided into two groups: who received electrical stimulation and those who don't. And in this study, electrical stimulation was given with biphasic triangle wave stimulus for 10 minutes in a session, 2 times in a week, 5 days, 2 times in a day, 5 days in a week, and for 100 to 500 milliseconds, and a current of 5 to 27 milliampere. And Pauls et al. Found no difference in renervation time between individuals who received and didn't receive electrical stimulation. But they found less synkinesis with electrical stimulation in the group that didn't receive surgery. In the case report, in which the restorative potential of intense electrical stimulation was investigated in a patient with long-term quadriceps femoris muscle total denervation, the patient received electrical stimulation after 18 months after the injury. 2 pairs of large electrodes were connected to the front surface of the thighs on proximal and distal portions. And in the first 4 months, patient received electrical stimulation at 2 Hz for 14 minutes in a session, 1 time in a day, and 5 days in a week. And after 4 months, patients receive electrical stimulation at 20 Hz for 14 milliseconds, 2 seconds on and 2 seconds off for 15 minutes in a session, 1 time in a day, and 5 days in a week for a total of 26 months. And they found decreased quadriceps femoris atrophy with knee torque sufficient to stand up without upper extremity support. There are also findings in the literature that short-term low-frequency electrical stimulation accelerates axon growth and muscle reinnervation after emergency neurosurgery in rats and human patients. And in the study done by Elzinga et al. In 2015, rats' common peroneal nerves have been chronically axotomized, and or tibial nerve Schwann cells and ankle extensor muscles have been chronically denervated with ligation and transection. After the surgery was performed 3 months later, sham stimulation was given to one group, and electrical stimulation at 20 Hz was applied to the other group for 1 hour with wire electrodes. And they found that electrical stimulation significantly increased the number of both motor and sensory neurons undergoing axonal regeneration, and they found it effective in improving target reinnervation after delayed nerve repair. And in this study, the sciatic nerve of rats was cut, and the repair of nerve damage was delayed for 2, 4, 12, and 24 weeks. After these periods, one end of the wire electrodes was fixed in a ring around the nerve stump proximal to the lesion, and the second electrode used as an anode was placed on a muscle close to the nerve. And in this study, electrical stimulation was given at 20 Hz and 3 volts for 20 minutes. And Hung et al. Found a significant increase in the diameter of the regenerated axons and the thickness of the myelin sheath, as well as the number of motor and sensory neurons. An increased amplitude of the compound muscle action potential and nerve conduction velocity in the gastrocnemius muscle was found also. So we can say that according to this study, muscle atrophy is reversed partially. Effectiveness of electrical stimulation decelerated gradually with delays ranging from 2 to 24 weeks. Application of electrical stimulation after delays of up to 24 weeks can support nerve regeneration and increase functional recovery. In a study with the opposite result, the extensor digitorum longus muscle of rats was subjected to 3.5 months of denervation by perineal nerve exotomy, and in this study, electrical stimulation was applied to some rats during the denervation period. The result of the study revealed that electrical stimulation applied during the denervation period didn't improve muscle mass, strength, or motor function. Although there are studies stating otherwise, in the light of many studies in the literature, it can be said that electrical stimulation still has the potential to increase regeneration after chronic nerve injuries or delayed nerve repair, but of course, early treatments gives better results. As conclusion, when the literature is examined, it is seen that the results of neuromuscular electrical stimulation in the treatment of completely denervated muscles are inconsistent. And it is thought that one of the reasons for the discrepancy in the results may be muscle damage and fatigue caused by the high electrical intensity used in some studies. Therefore, physiotherapists should take measures to avoid overstimulating or exhausting the surrounding muscles in particular. Obstacles to the use of electrical stimulations are the inability to clearly understand the mechanisms by which functional recovery is performed, the inability to decently optimize stimulation settings, and the inability to characterize the effect on the cranial nerves. Clinical trials demonstrating the effects of electrical stimulation on nerve regeneration are relatively new. The selection of stimulation parameters and models used in the studies is mostly done by trial and error methods because of this reason. To solve the problem of using electrical stimulation to benefit denervated muscle depends on the appropriate stimulation parameters, stimulation current and type, and correct placement of electrodes. The lack of clarity in terms of application in the studies leads to continuing barriers to the use of electrical stimulation in patients despite the positive effects proven in current studies. And I have to say that electrical stimulation is not suitable for people with heart disease, pacemakers, risk of bleeding, and risk of thromboembolism. Caution should be also be exercised when using it on people who are pregnant or have epilepsy, sensory impairment, or joint replacement. And electrical stimulation shouldn't be applied on the carotid sinus, through the thorax, on the diseased skin, or in the laryngeal region. Considering the important points in practice, it is important for physiotherapists using electrical stimulation to further decipher the effectiveness of electrical stimulation on nerve regeneration in the human population without ignoring the results of studies. And these are the references of this chapter. You can also review them. And I am in the end of my presentation now. Finally, this is the theme of our project. It is a pleasure to be in this project, and I am very happy to make this presentation to you. Thank you for your attention.